morning to everyone. I will start that again. Good morning, good afternoon, good evening to everyone, depending on where you're joining us from. Thank you for joining us today. Our webinar today is titled Integrating Mental Health and Psychosocial Support into Infant and Young Child Feeding in Emergencies. This webinar will be conducted in English. Translation is available in 3 languages, that is French, Spanish, and Arabic, and is accessible by clicking the globe icon on the bottom of your screen. This webinar will be recorded so that you can share the recording with anyone who was not able to attend. The recording is in progress already. Please introduce yourselves in the chat, who you are, your name, where you're listening in from, so that we can all know who we are here. To some housekeeping rules, please keep your mics and cameras off. If you have any questions about the presentation or that you would like to bring to our presenters' attention, please put those in the Q&A box. It is next to the globe icon at the bottom of your screen. We will ensure that we will take time throughout the webinar to answer your questions in the Q&A box. And if there's any other outstanding questions, they will be answered in the Q&A session of our webinar. And in case we run out of time, unanswered questions will be responded to and shared after the webinar. If you have any other general questions or comments, you can put this in the chat. Slide 3, please. This webinar is organized jointly by the Global Nutrition Network, the MAMI Global Network, and the IFE core group. On slide 3, you will see the logos of all the member organizations and independent members of the IFE core group with our working group, as well as our donors, without whom delivery of this webinar would not have been possible. I would also like to take this opportunity to extend our thanks to our colleagues, Miriam Yanakis at the GNC and Rachel Menezes from the Emergency Nutrition Network for all the technical support to make this webinar work, and also all the presenters as well and the facilitators. Thank you so much. Next slide, please. Just to give a quick overview of the IFE core group. The IFE core group is a global collaboration of agencies and individuals committed to the protection, promotion, and support of appropriate infant and young child feeding in emergencies. It was established in 1999 and was created to respond to concerns and gaps related to infant and young child feeding in emergencies. The IFE core group is dedicated to ensuring more effective IYCF support in emergency contexts by strengthening learning, guidance, and policies, planning, and capacity in IYCF. The QR code on this slide will take you to the resources, to the key resources on infant and young child feeding in emergencies produced by the IFE core group. Next slide, please. Here we have our presenters. Some are independent members and some are representing organizations. They all bring together different expertise to the conversations we will have today. On the next slide, we have objectives. With the overall objective of this webinar to ensure that all our participants have a clear understanding of and practical capacity to apply a trauma-informed, integrated approach to mental health and psychosocial support and infant and young child feeding in emergencies, promoting caregiver well-being and infant and young child feeding practices are addressed holistically in humanitarian context. Some of the specific objectives we are hoping this webinar will cover will be understanding the evidence and linkages, present evidence on how maternal stress, trauma, and psychosocial well-being influence IYCF practices and nutrition outcomes, and illustrate what improves infant and maternal mental health. And with that, I will be able to hand it over to Alex. Alex, over to you.
Thank you, Anne. And yes, have a great day, colleagues, wherever you are around the world. So the agenda is very straightforward for this activity. So we have a bit of introduction, as you have heard already, and my role is to introduce a bit of the evidence and some of the approaches we could deploy, we could implement in relation to stress and infantile and child feeding in emergencies. There will be a role play, and our colleague Jodine will give you more details on that. Some reflections, some polls, some question and answer, hopefully some commitments, some next steps, and a closing and an evaluation. During the webinar, we are going to use some acronyms. Maybe many of you, most of you, perhaps all of you are very familiar with it, but please, if not, take note of the very few that we're going to use. And we will always try to spell it out, but basically IYCF and IYCFE, MHPSS in terms of mental health and psychosocial support, PFA is our psychological first aid, TIC is trauma-informed care, as well as MAMI, the management of small and nutritionally at-risk infants under 6 months and their mothers. So let's start with the first poll, and I would like to ask my colleague Rachel to please launch the poll and for all of you to respond. The poll, and I'm going to read it, is: which trauma-related, either mental or physical experiences most commonly affect pregnant women and mothers in your context? So you have potentially 6, even more answers: exposure to injury from disaster, sexual and gender-based violence, loss of access to essential care, lack of food, supplies, and water, loss of support networks, partner and family separation, exposure to traumatic events, including violence, anxiety and depression, caregiving-related stress, grief and loss, uncertainty about the future, displacement, and few others. So I hope our interpreters are able to help translate it, interpret it in the other languages, so we can give an extra minute for it, and then we'll close the poll. Okay, I don't see more answers coming. So I will end the poll also in the interest of time. So apologies if you are still thinking what answer to give, but I'm going to close the poll. Apologies again. And let's see. So as we can all see, in all the colleagues around this call, in all the context you are working, you are basically confirming there is a diverse set of traumas that women, pregnant women and mothers are experiencing, and are experiencing most likely also as we speak. So it's very important to understand how all of these type of traumas affect or may affect their infantile and child feeding, among other things, of course, not just infantile and young child feeding. But as you see, really, there is a very diverse presence of traumas, both mental and physical, that pregnant and mothers are experiencing in our context. So thanks for sharing that. So let me close this, and I already let me close this. So let's go a bit on some of the evidence that we may be already familiar, but it's important to reaffirm as a basis for the conversation we are just starting. We know that there are several stressors. The situation that causes stress in a humanitarian context, we can just mention displacement, violence, loss, insecurity, uncertainty, and the disruption of social networks, livelihood, and services. So all of these causes stress. So we know that stress, in a way, or distress, is expected in certain context. And we know also that either there are already pre-existing vulnerabilities to distress or stress, or the crisis has opened those as trigger such a situation. And again, prolonged emergencies are also certainly compounded by all of these stressors. Again, this is just to reiterate the evidence that during pregnancy and the lactation period, and for breastfeeding and lactating women, this period of their life increases their vulnerability toward stress. And so emergency, humanitarian situation compound already the biological, psychosocial, and service-related stressors. So it's a very peculiar, very particular period of the life course where, again, there are increased vulnerabilities, to the point that the evidence suggests that around 20 to 22% of mental health conditions in conflict-affected populations it has been measured around 22%, and that during the perinatal period, we have around 15 to 20% of women affected globally with very high rate, with much higher rates in emergencies, in emergency context. So we know what are the stressors, but we also know, and that's very critical, and I hope you will take note of that, that social connection is a biological buffer to stress. We know that supportive relationships calm the nervous systems and reduce stress hormones, the cortisol. We know that living in isolation or being isolated or being alone activates pain and stress pathways. So it's critical that we understand the role of social support and the role of social support in protecting mental and physical health during an emergency context. And what do we mean by social connection? This can take many forms. So peer support, I'm sure we are all familiar with mother support groups, family support systems, and other community networks. So the question of why do we need to integrate mental health and psychosocial support with IYCFE, I think it's becoming, I would say, obvious, where we know the stressors, we know what causes distress, in particularly to pregnant women, women with young children and infants. And as we will see in a while, we know that all of this may cause some disruption to breastfeeding practices and the infant and child feeding practices as a whole, including complementary feeding. And eventually this will increase or increases the risk of malnutrition in an already very complex situation. So the key answer to why do we want to integrate MHPSS and IYCFE is basically because integrating protects infant and young child feeding as well as the caregiver capacity to nurture and survive and thrive in that context. One of the most recent evidence have shown, as I said, that maternal depression is a significant barrier to optimal exclusive breastfeeding. So again, this is to show how if we don't address these stressors and the distress that they cause, well, we have also a major impact on the way the child is being nurtured and fed. This is I know is a bit of a complex at first diagram that shows the interaction between the baby and the mother relationship, but it's basically one message that the relationship between mother and baby is a two-way relationship. And the key message that we want to leave, from this slide is basically that having mental health and psychosocial support and a trauma-informed care that applies to all caregivers help address the two-way relationship, the concerns around the two-way relationship that may manifest around both the mother as well as the infant. Another piece of evidence that we really wanted to share, and again, I'm sure you're all very familiar with it, is to reiterate some of the basics around lactations, and is around the hormones that are contributing both to the production as well as to the release of breast milk. So we know about prolactin, and we know about oxytocin, the hormone that helps with the letdown of breast milk. And we know when they work and we know how they work, but it's very critical, again, just to go to the key message that we wanted to share with you all, is that one is to misspell a myth. Stress, fear do not generally affect breast milk productions, but it may have some effect on oxytocin, as you can see from the image on the right, as well as from this diagram from a WHO training package. So we know that oxytocin is hindered, no, by being worried, by being stressful, being in pain and doubtful. But there are other actions that, for example, the touch of the baby, the sight of a baby, the sounds of a baby, helps in the production of oxytocin and the letdown of the breast milk. So again, just to be very clear, we know that stress may have some effect on the action of oxytocin, may weaken temporarily the letdown reflex, hence the importance of working on with a trauma-informed care approach, and hopefully with some mental health and psychosocial support actions to support women and work with them and help them in addressing those concerns. So these are some of the references. We have been discussing briefly about breastfeeding and how the relationship between mental health, stress, and fear, and distress in general may affect breastfeeding and breastfeeding practices. But also recent evidence shows that stress can also affect complementary feeding. As you can see, the evidence shows that infant feeding behaviors also during complementary feeding are influenced by family dynamics. Maternal stress is associated with lower dietary diversity for children and altered feeding practices, including the timing, the introduction, the quality, etc. Hence, it's very critical, sorry, in the context where we usually work in humanitarian settings, to understand that heightened stress, disrupted routines, and reduced social support may also undermine responsive complementary feeding, even when food may be available. And this diagram here is just meant to reiterate the fact that caregiving relationships basically shape, with feeding interaction, shape infant mental health, and improving or protecting caregiving relationship is actually a mental health intervention. So what can we do? So there are several approaches and tools that we can use to support caregivers, their infants and young children. So we have been mentioning MHPSS, we have been mentioning PFAs, and we have been mentioning TIC, the trauma-informed care. So mental health and psychosocial support is basically the set of actions that we can deploy, implement, actions and services to support, for example, pregnant women and women with young children. PFA is basically a practical way to help someone that was detected in a very distressed situation. While, and again, this is a concept we will reiterate all throughout this webinar, is the way we deliver all services every day of our work, every day of our life, with all caregivers, regardless they are distressed or they are manifesting any form of distress, any caregiver involved, in infant and young child feeding. So not just the mother, but also the fathers, the grandmothers, and others. So this slide is starting to shed some light on how do we differentiate these various concepts. So a bit more details. I will not use all the information for the slides that are coming in the interest of time, but basically, again, MHPSS is the set of actions, is the set of interventions. So we talk about peer support groups, we talk about child-friendly spaces, caregivers groups, case management and referrals, and so on, that we can use to support, as I said, and as it's reiterated in this slide, people's mental health. So again, it's a set of actions and services. While PFA is a tool we can use to assess the safety and the needs of in this case, of the mother, of a pregnant woman. It helps us listen with empathy and without pressure, the person that is in front of us, and eventually link the person that we feel needs such a linkage to relevant information, services, and social support. As you can see, frontline humanitarian workers may be trained in providing it, as well as health staff, volunteers, and others. But let's spend a bit more time, and again, this will be unpacked all throughout this webinar on the main concept we really want to share with you, the trauma-informed care. It's about the way we work, the way we do our work, regardless of sector and context, and how we do it always. So there are core principles, like the importance of safety, both physical and emotional, of the client, of the mother, of the pregnant woman, the importance of trust and transparency, the importance of recognizing the importance of choice and autonomy of the mother, the importance of collaborating, and certainly the importance of being culturally and contextually sensitive. So what does it look like in practice? And you will see it even in a better way in a while. For example, offering privacy when we provide breastfeeding counseling, being compassionate while we listen, or being attentive to certain power dynamics that we may have or we may see in our settings. So what happens if our infant and child feeding services are not trauma-informed, or we don't practice the trauma-informed care? Basically, we may unintentionally increase distress in the person. We may reinforce the blame, especially towards the mothers. We may undermine her confidence. But if our services, or the person that are offering the services, are applying those basic principles of trauma-informed care, usually caregivers are more likely to feel safe and respected, and we're able to build the trust and engage meaningfully, even in very constrained settings. So again, this is just a reiteration, a repetition of what we have been saying in the past few slides. MHPSS is setting up some interventions like caregiver groups where women, pregnant women, can receive the support among even peers. And maybe more importantly, just again in the interest of time, is the reiteration is trauma-informed care is really about our way of offering, of working, of providing the services, the counseling, for example. And this is regardless of the way the mother is feeding or not feeding, and the context where the mother is. This is a very informative diagram we call the multi-tiered approach to trauma-informed care. You can find it in the operational guidance for breastfeeding counseling in emergencies. I just want to emphasize one message. Trauma-informed care is not for specific staff, sorry, only, but it's a universal set of principles. And we hope that this is a key message that you will all take home. It should be provided by all counselors to all caregivers. And again, it's basically, if you look at the bottom of this pyramid, it's basically ensuring that there is consent, that there is compassion, there is respect, we are listening when providing basic health and nutrition services, including infant and child feeding counseling to our women. A few more slides before I give the floor to my colleague. there will be time we will need to refer during our counseling sessions, the infant and child feeding counseling sessions, we may see or we may detect the risk of harm both to the caregiver of the infant. If we see or we hear that the mother has some suicidal thoughts or severe distress, or if we understand that, for example, the mother is not able to care for her infant. Obviously, there are also situations, and we are very aware that referral to other services may not always be available. So continue using those trauma-informed care principles. If trained, provide the PFA support, link with family and peer support, and plan follow-up and monitoring. So in short, we know that, and that's the whole message of this presentation, stress and feeding, and the way we feed, the mother feeds may affect caregiving, both for the mother and the child. And critical infant mental health starts with caregiving. The way we deliver services matters. It's not just being technically correct, but it's how, and that's the trauma-informed care principles. And again, safe, respectful relationship are stress regulation interventions. So what can we do? There are several things we can do. This is just an example. Ensure that we apply a trauma-informed care in every interaction with our mothers, with our women, but not only. If possible, train our staff on PFA when needed. Use breathing exercises. The role play will tell you more. Refer and follow up if and when services are available. And again, small changes in the way we listen to the women when we provide the services matters. Over to you, Rachel.
Thanks, Alex. Yes, we just wanted to take a couple of minutes to share some useful resources and tools with you all. So here we have listed 2 examples of key assessment tools that you could use in practice. We have the MAMI assessment form, which includes a maternal mental health assessment. And we have the IYCF simple RAP assessment and full assessment here as well. We've also included various resources on counselling and general support here too. Next slide, please. Thank you. Yes. We also wanted to share some examples of what this looks like in practice. So we have a list of case studies here that document or evaluate integration of MHPSS into IYCFE. Definitely some good case examples here if you want to further explore what integration looks like practically. Next, please. And last but not least, we wanted to take the opportunity to highlight some of the key resources from the MAMI Global Network on MHPSS and relaxation for mothers. I've already mentioned the MAMI assessment with the maternal mental health assessment in the first resource slide, but as well here we have the assessment guide on how to use the form. So you can see here what it looks like. And it's a really simple, practical assessment that can be contextualized for the setting that you're working in. And this is specifically for infants under 6 months old and their mothers. We've also linked here a video example as well as a resource list on some of the relaxation techniques you could employ, such as deep breathing and progressive muscle relaxation. But please note all of these slides and the resources will be shared with all attendees after the webinar, so you can go back and look through them in your own time. But I hope you find these resources useful, and I will pass back to you, Alex. Thank you.
Yeah, wonderful, Rachel. And again, this is the end of the presentation. So I'm going to give the floor to our wonderful colleague, Jadine Chase, and she will guide us through this exciting section. Over to you, Jadine.
Hello, Alex. Thank you very much, and hello to everyone. In a few moments, we'll be playing a video. We'll play it right through the first time without stopping, and then we'll play it a second time. And where you see the word pause, we will stop for explanation and reflection. But let me first set the scene for you. So around the world, millions of people are forced to flee their homes because of conflict and violence and natural disasters. We are seeing more complex emergencies where communities are impacted by multiple concurrent disasters. As you can see in these images, large numbers of people are being displaced. Go ahead and move to the next slide, Alex. Often with little warning, families are forced to leave their homes quickly, arriving only with what they can carry. And so the video you are about to see, go ahead and move to the, thank you, next slide, is a role play, and the location could be in any one of these settings. So now I will take over the screen and I will play the video.
Hi, my name is Mona. I'm a nutrition worker trained in infant and young child feeding. Would you like to have a seat? Would it be okay if we talked for a few minutes? I know this isn't a very private space. Is there anything I can do to help you feel more comfortable?
Thank you. It is quieter in here.
Would it be all right if I ask you a few questions about you and your baby? I want to assure you that everything we talk about today is confidential between me and you. If you want to talk to someone else, we can do that. I really want you just to feel comfortable. We are here for you and your baby. Can I ask you what your names are?
Thank you. It is nice to be speaking with you. I am Sarah. This is Mira.
Before we start, I want to make sure the space is safe and comfortable for you. Is there anything that you need right now?
I am very thirsty. I have not had anything to drink today.
Please, here is clean drinking water that I can offer.
Thank you.
Now, how are you, Sarah?
We've lost everything. I don't have my family nearby. It's just me and my babies. I feel very afraid and worried.
I hear that you're afraid and worried and concerned about the children. We're here to help in any way that we can. Let's come up with some ideas together.
Thank you.
How old is Mira?
She was born at the start of the dry season.
So about 2 months old then? And before you had to leave your home, how were you feeding her?
I breastfed her.
And how are you feeding her now?
I'm still trying to breastfeed her, but she fusses a lot and then she wants to feed again. And I don't know if I have enough milk, if she's getting enough milk.
It's okay to feed Mira here if you want to. It might be helpful for me to see a feed. And it's cold. Is it okay if I place this blanket over you? It might help to keep you warm, and it should offer a little more privacy while you feed.
Thank you. I also have another child. He is 2. Feeding him seemed a lot easier.
It sounds like you're really worried about Mira. Many mothers feel this way after everything that's happened. I can hear the baby swallowing. I can see her hands relax there. That's what we're looking for. Your body is responding even under a lot of stress. You're strong.
Yes, this is good. I can feel the milk coming.
This situation is unstable and frightening. Sometimes the stress can delay the start of milk flowing. Sometimes you might not feel it right away.
Sometimes it's hard to relax.
Is there anything you can do in your tent to help feel more comfortable, to encourage the milk to flow, just like it is now?
I can put a blanket behind me and lean back on it.
That's a great idea. Even through all of this, your body is strong. It's doing it. Your body's still able to make milk, and we can support that together.
She seems to want to feed more often than before.
Your baby loves you very much, and when she's stressed, she wants to be at the breast more often. Fussy doesn't always mean hungry. Your baby is so smart. Being there comforts her.
She is so smart. I love her very much.
It's very clear. I see that you love her so much. I see that you're doing a great job with her. We can talk a little more while she feeds, if that's okay. Have you been able to find food for yourself and your older child?
Only what we were able to bring, and we are running out.
I can share information about food distribution points and when they're open. We can talk through it together. You don't need to stop feeding.
Okay, thank you.
Do you think maybe you could come back so we can see how she's doing?
Yes, I will try.
Here's a list of resources for you to look at later. Is there anything else that you might need that I could help you with?
Thank you. Not right now.
You're doing something very important for your baby.
I feel better about her feeding. Thank you.
Hello, how are you?
Oh, thank you.
So good to see you again. How have things been going since we last spoke?
Feeding is much better. Thank you. And she's smiling now.
Oh, she's beautiful. Do you want to have a seat?
Yes, thank you.
She's so cute.
Yes, I'm very tired. She feeds all the time. My son needs me too, especially since my husband and my mother-in-law have not been back since I don't know where they are. Everything feels like too much.
I hear you. That sounds very hard. I can sit with you and I can listen if you have time. When things feel heavy, what helps you feel a little better?
When Mira breastfeeds and when she is calm.
When we saw each other before and the milk didn't flow right away, you were able to relax. Anytime you feel stressed or overwhelmed, you can take a deep breath. Have you heard of box breathing?
I don't think so.
It's a slow breath in for 4, pausing for 4, then a slow breath out for 4, then pausing for 4, and then it repeats. We can do it together. Would that be all right with you?
Yes.
Okay, so breathe in to the count of 4. 1, 2, 3, 4, hold. 1, 2, 3, 4. Breathe out. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Repeat. Inhale. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Exhale. 1, 2, 3, 4. Hold. 1, 2, 3, 4. It looks like you may be relaxing now. How are you feeling?
The breathing was good.
And you can do this breathing anytime you want, anytime you feel upset. It's not just for feeding. Is there someone here you trust, another woman or a neighbor?
Yes, the woman next to me, my son is with her right now.
It's great to hear that you have support. We're also here to help you. You can come anytime, even if it's not about feeding.
Thank you.
One step at a time, you're doing well. There are women here who you can talk to. There's a group of mothers from the camp that meet once a week to share their experiences. We call it a mother-to-mother support group, and sometimes grandmothers and friends come too. It's happening in the next tent if you'd like to have a look.
Yes, I would like that. I feel lonely sometimes.
And if you need, there's other support available if you're feeling overwhelmed or tired. I can introduce you to one of the counselors if you'd like.
Yes, I would love that. Thank you.
Take this information. It has information about our support group, the time, and the services, and also it has information about the counselors and how to sign up. There's also information about the breathing exercises. You can do that with your friend or on your own. We're all here to support. Feel free to come back anytime.
Thank you. This has been really helpful.
All right, now we will watch the video again, and this time we'll pause for explanation and reflection. I will also stop talking before we begin the video after the pauses, and you'll hear silence on the English channel for a few seconds. This is to allow the translators to catch up.
Hi, my name is Mona. I'm a nutrition worker trained in infant and young child feeding. Would you like to have a seat? Would it be okay if we talked for a few minutes? I know this isn't a very private space. Is there anything I can do to help you feel more comfortable?
Thank you. It is quieter in here.
Would it be all right if I ask you a few questions about you and your baby? I want to assure you that everything we talk about today is confidential between me and you. If you want to talk to someone else, we can do that. I really want you just to feel comfortable. We are here for you and your baby. Can I ask you what your names are?
Thank you. It is nice to be speaking with you. I am Sarah. This is Mira.
Before we start, I want to make sure the space is safe and comfortable for you. Is there anything that you need right now?
I am very thirsty. I have not had anything to drink today.
Please, here is clean drinking water that I can offer.
Thank you.
So let's pause here to look at a few key trauma-informed actions. First, a reminder, as you heard before, we know that any woman receiving infant feeding support in any setting may have experienced trauma, so we offer trauma-informed care as an approach for all. So now let's notice how Mona starts the conversation. She introduces herself, she names the limits of the space, and she asks permission before continuing. She also checks whether Sarah feels safe and whether she needs anything right now. Being conscious of power imbalance, Mona sits at eye level, offering choices and letting Sarah set the pace. These small steps build safety, trust, and choice. Mona also gives Sarah options, including the option to see someone else. This keeps control with the mother. In emergencies where people have lost control of almost everything, this is how trust begins.
Now, how are you, Sarah?
We've lost everything. I don't have my family nearby. It's just me and my babies. I feel very afraid and worried.
I hear that you're afraid and worried and concerned about the children. We're here to help in any way that we can. Let's come up with some ideas together.
Thank you.
How old is Mira?
She was born at the start of the dry season.
So about 2 months old then? And before you had to leave your home, how were you feeding her?
I breastfed her.
And how are you feeding her now?
I'm still trying to breastfeed her, but she fusses a lot and then she wants to feed again. And I don't know if I have enough milk, if she's getting enough milk.
Here, Mona asks just 3 simple structured questions from the IYCF Simple Rapid Assessment. Well, the goal is to do a full assessment. We don't always have time, and that's okay. Here in this video, we're not showing every step. We're showing interactions and how to ask questions. Notice how Mona listens carefully and does not correct or challenge or judge Sarah's responses. She lets Sarah finish speaking, which is respectful and supports Sarah's sense of control. The priority is understanding the caregiver's experience before offering guidance. You may have noticed that Sarah talks about fear and worry. She doesn't use the word stress, and she doesn't need to. In an emergency, we should assume that stress is present, even when it isn't named, and response with empathy and patience.
It's okay to feed Mira here if you want to. It might be helpful for me to see a feed. And it's cold. Is it okay if I place this blanket over you? It might help to keep you warm, and it should offer a little more privacy while you feed.
Thank you. I also have another child. He is 2. Feeding him seemed a lot easier.
So, pausing again, notice that Mona asks for permission before placing the blanket. Even small physical actions require consent. This reinforces safety, respect, and agency, and continues to build trust, even in a context where control is often lost. In emergencies, privacy is also often lost. Cultural norms around breastfeeding and personal space are often disrupted, which can increase distress and vulnerability. Cultural sensitivity here is not about knowing customs in advance, but rather it's about asking, observing, and not assuming, especially around family roles, lived experience, feeding, and privacy. It's about allowing the caregiver to define what feels safe and acceptable to them. Trauma-informed care means we actively restore dignity. We do this through simple actions that protect privacy, safety, and comfort. Now, we're going to do another poll. So I'll wait for the poll to come up on the screen. Here we go. Which actions may need to be adapted depending on context, safety, consent, or culture? And your options are skin-to-skin contact in the presence of the healthcare worker, demonstrating and supporting breast massage, encouraging healthcare worker eye contact or touch with mother or child, breathing exercises, providing a quiet or private space, who is present in the space for the counseling session. So go ahead and vote, and in a few moments, we will take a look at the results. Just give you a little bit of time to make your selection. And of course, we will pause for the translators a little bit here. All right, so let's see the poll results. And we can see that a lot of people have noted that skin-to-skin contact is an important contextual adaptation. The breathing exercises may need a little bit of adaptation. The need for privacy and space is really important as well. Who's present in the space, of course, for the counseling session. These are all things that are depending on cultural context. All right, now, so we'll move on back to the video.
It sounds like you're really worried about Mira. Many mothers feel this way after everything that's happened. I can hear the baby swallowing. I can see her hands relax there. That's what we're looking for. Your body is responding even under a lot of stress. You're strong.
Yes, this is good. I can feel the milk coming.
This situation is unstable and frightening. Sometimes the stress can delay the start of milk flowing. Sometimes you might not feel it right away.
Sometimes it's hard to relax.
Is there anything you can do in your tent to help feel more comfortable, to encourage the milk to flow, just like it is now?
I can put a blanket behind me and lean back on it.
That's a great idea. Even through all of this, your body is strong. It's doing it. Your body's still able to make milk, and we can support that together.
She seems to want to feed more often than before.
Your baby loves you very much, and when she's stressed, she wants to be at the breast more often. Fussy doesn't always mean hungry. Your baby is so smart. Being there comforts her.
She is so smart. I love her very much.
It's very clear. I see that you love her so much. I see that you're doing a great job with her. We can talk a little more while she feeds, if that's okay. Have you been able to find food for yourself and your older child?
Only what we were able to bring, and we are running out.
I can share information about food distribution points and when they're open. We can talk through it together. You don't need to stop feeding.
Okay, thank you.
Do you think maybe you could come back so we can see how she's doing?
Yes, I will try.
So here we see practical feeding support offered. Mona doesn't instruct or correct. She offers suggestions and she affirms Sarah's decisions, supporting her autonomy and her choice. Mona does not provide too much information all at once. The baby has latched and milk is flowing, so she saves suggestions for positioning for a follow-up visit if appropriate. Mona also checks on food access for the whole family and reassures Sarah that the conversation can continue without interrupting the feed. This reinforces that breastfeeding remains the priority. We don't see it, but it's important to know that Mona has already investigated to set up referral pathways and mapped access to food, wash, and shelter. She is proactively working to reduce stress and vulnerability. Checking on food access for the whole family acknowledges the bigger picture and explores a potential additional source of stress for Sarah, showing empathy and understanding of her lived experience. Trauma-informed care isn't about perfect conditions. It's about creating enough safety and trust for optimal caregiving to continue, even in very difficult circumstances. So here we're going to do another poll. And this one has quite a few answers. So if you don't see everything on the screen, you can go ahead and scroll down. What would encourage or support trauma-informed follow-up that is possible in your context? And go ahead and select all that apply for you. Phone or messaging follow-up, outreach or mobile visits, peer support to staff, child-friendly spaces, private and safe counseling locations, support from family or peers, clear consent and safeguarding procedures, integration with existing communities, referral or tracking systems, involving affected populations in program design, confidential communication systems, inclusion of fathers or other partners, or anything else that you can think of. We'll take a few minutes to do this poll. We'll just give you a little bit more time, especially if you're typing responses in the other section. All right, let's close the poll and take a look at what people are saying. Oh, I think this is a great reflection. Again, a lot of people are noticing the importance of privacy and safe counseling locations. And I see referral and tracking systems. Inclusion of fathers or other partners is a really important area and one I know some of our colleagues are exploring. Just have another quick look to see what else we see here. Support from family or peers, very important. Child-friendly spaces, outreach, mobile visits. All right, let's move on now, and we'll take another look at the rest of the video.
Here's a list of resources for you to look at later. Is there anything else that you might need that I could help you with?
Thank you, not right now.
You're doing something very important for your baby.
I feel better about her feeding. Thank you.
Hello, how are you?
Oh, thank you.
So good to see you again. How have things been going since we last spoke?
Feeding is much better, thank you. And she's smiling now.
Oh, she's beautiful. Do you want to have a seat?
Yes, thank you.
So this moment highlights the value of the trust that was built in the first visit and demonstrates how early rapport and a non-judgmental approach supports emotional safety and engagement. Sarah's first experience of safety and respectful exchange made it more likely for her to return. That also supports her continuing to share more of her concerns. Because she's able to disclose information at her own pace without feeling pressured or overwhelmed, even if a different worker were present, it's more likely, of course, as is more likely in real life, they would be able to build on Sarah's positive first experience.
She's so cute.
Yes, I'm very tired. She feeds all the time. My son needs me too, especially since my husband and my mother-in-law have not been back since I don't know where they are. Everything feels like too much.
I hear you. That sounds very hard. I can sit with you and I can listen if you have time. When things feel heavy, what helps you feel a little better?
When Mira breastfeeds and when she is calm.
When we saw each other before and the milk didn't flow right away, you were able to relax. Anytime you feel stressed or overwhelmed, you can take a deep breath. Have you heard of box breathing?
I don't think so.
It's a slow breath in for 4, pausing for 4, then a slow breath out for 4, then pausing for 4, and then it repeats. We can do it together. Would that be all right with you?
Yes.
Okay, so breathe in to the count of 4. 1, 2, 3, 4, hold. 1, 2, 3, 4. Breathe out. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Repeat. Inhale. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Exhale. 1, 2, 3, 4. Hold. 1, 2, 3, 4. It looks like you may be relaxing now. How are you feeling?
The breathing was good.
And you can do this breathing anytime you want, anytime you feel upset. It's not just for feeding. Is there someone here you trust, another woman or a neighbor?
Yes, the woman next to me, my son is with her right now.
It's great to hear that you have support. We're also here to help you. You can come anytime, even if it's not about feeding.
Thank you.
One step at a time, you're doing well.
At this point, we can see Mona has recognized that Sarah needs more than feeding support. Mona offers a simple breathing technique that builds on what they've already done together. It helps with milk flow and it helps manage feelings of stress, allowing Sarah to feel more in control of her situation. This is a practical strategy that respects Sarah's autonomy and choice. This is one approach to managing stress, and there are, of course, other simple techniques that might be effective in your context. Notice that Mona does not diagnose or counsel deeply or promise solutions. Trauma-informed care does not require a diagnosis or being a mental health specialist. It requires listening, validating, offering simple strategies, and linking to peer support and referral where available.
There are women here who you can talk to. There's a group of mothers from the camp that meet once a week to share their experiences. We call it a mother-to-mother support group, and sometimes grandmothers and friends come too. It's happening in the next tent if you'd like to have a look.
Yes, I would like that. I feel lonely sometimes.
And if you need, there's other support available if you're feeling overwhelmed or tired. I can introduce you to one of the counselors if you'd like.
Yes, I would love that. Thank you.
Notice how support is offered as a choice and not a requirement. This keeps Sarah in control of the decisions, which builds her confidence and her ability to breastfeed and to manage her situation. Access to the peer support group and the referral to mental health counseling are also framed as options, not requirements. In contexts where mental health referral is not an option, peer support takes on an additional importance. Exploring protection services together, like gender-based violence or child protection, are also options.
Take this information. It has information about our support group, the time, and the services, and also it has information about the counselors and how to sign up. There's also information about the breathing exercises. You can do that with your friend or on your own. We're all here to support. Feel free to come back anytime.
Thank you. This has been really helpful.
So Sarah is on her way to the peer group session, and Mona will be taking a well-deserved self-care break. It's important to reinforce and support our own mental health in this work. So I'm going to turn this over now to Brooke Bauer. Brooke will be leading a reflection and question and answer session. Brooke, go ahead.
Great, thanks, Jodine. We're gonna be bringing up the slides.
Yeah, I'm going to
No.
do it right away, Brooke. Just a sec.
No worries. I wanted to talk about, as we go into the Q&A, talk about some of the comments in the chat that we've been having, really useful and insightful about comments about really meeting the mother, meeting the family where they're at, kind of giving that comprehensive understanding of what she mentioned, the mother mentioned a second child, and really going into kind of what that means and how we might be able to support the entire situation. We didn't go into a full, Jodine said earlier, but we didn't go into the full assessment in this situation, which is what we would normally do. So really making sure that we're checking in, we're learning about the older child, we're learning about the entire context and the entire situation to provide that overall support. So great comments in the chat. Some of the takeaways as we begin to go into the Q&A and close out the session, we want to really highlight, and it was said also in the chat, caregiver well-being and infant feeding, they're inseparable. right? We have to look at this from with the entire picture. Distress can disrupt breastfeeding and complementary feeding through various emotional and physiological pathways. So we want to make sure that we're looking at the person and the relationship as a whole. Social support is a biological stress buffer. Connection and supportive relationships, which is, I think Pony said in the chat, it's protect caregiver capacity. It stabilizes feeding interactions for all the caregivers with young children. And then overall, trauma-informed care is everyone's responsibility every day, right? It's not a specialist add-on. It fits within this overall umbrella of MHPSS and within these referrals, but it's for many of you who are healthcare workers, for example, we wear gloves as a universal precaution for everybody and to protect everybody and to protect ourselves. Trauma-informed care should be considered in a similar way. It's not an add-on. It's how all services should be delivered with these approaches of connection and support and judgment-free, right? MHPSS, PFA, and trauma-informed care, they're complementary. MHPSS is the system. PFA is the practical tool for acute distress. Trauma-informed care is the universal way that we deliver services. Small changes in how we listen and interact can improve these outcomes. So privacy, asking for consent, non-judgmental language, compassionate listening. And I know that these are very difficult in the contexts where we work. And we might not, sometimes we look at the picture and we think we have all of these things that we have to do. We have to do a full assessment. We have to do another assessment. It has to fit in with this. We have to have the referrals in place. But as a first starting point, we can take these small changes and really listen and interact and take on what the family is coming to us with, right? Compassionate listening, and that can increase trust and uptake of the IYCF support. So we'll go into some of the Q&A now. And there's a few questions that are linked to, I'll start with this first question. There's fears out of maybe country colleagues on engaging non-specialist activities, assessments, when we're aware there's no specialist actors in the area to respond to mental health challenges that might be found. Is it a bad practice to start if we cannot refer? So the answer to that overall is no. Trauma-informed care in this way is a universal kind of precaution, a universal way that we should be doing our counseling and interacting within our IYCFE services. There are a lot of situations where there might not be a referral pathway available. And I'm sure many of us have taken a GBV disclosure and referral training and what to do if there's not a specialist in the area. It's very similar in this way, the trauma-informed care, that comprehensive support, compassionate listening, right? So we can start with that. It's just the way that we want to do our counseling. And then advocate if there aren't actors in the area. We can reach out to the Global Nutrition Cluster for support. We can reach out to our colleagues in our HQ perhaps, or in a different area of the country, to identify how to provide that more specialist support when those actors aren't in the area. I'm going to hand over to Najwa. Are you available to answer the context on starvation, or perhaps where it's more of a critical situation, and there are any special recommendations on how to guide the mother through this?
Thank you, Brooke, and this is an excellent question. Actually, we have noticed even in the fieldwork that stress changes parenting, and when starvation happen, or if there is IPC 5, mothers could be physically depleted. They could be irritable and emotionally numb. Milk supply may reduce, but most of the time or often does not fully stop, and shame and guilt are extremely high. But our guidance must be to avoid judgment, to avoid unrealistic expectations. You need to be clear about what your program provides, what doesn't provide, and prioritize survival and support the mother and the child as much as possible. And in such cases, like in Yemen and Sudan, and I'm sure it has happened in Gaza as well, we work with the parents to normalize their reaction. When there is not enough food, it is normal to feel overwhelmed, angry, tired, or hopeless. And this doesn't mean they are bad parents. And that is why we help through our programs to protect the feeding relationship. If the child is breastfeeding, we work on encouraging continued breastfeeding, even if food intake is low. Breast milk often continues even if the mother is malnourished and even if the child is malnourished. Frequent feeding, as Alex was saying, stimulates supply, and we encourage skin-to-skin contact. And when IYCF counseling is provided, we keep making comments to our teams in the ground to be very mindful and sensitive, because in the counseling we keep saying that you have to provide to your child a diverse diet that might not be available, which is why in most of the program we link to the MMP, we link to the food vouchers, and we link those families or the children we assess and their caregivers to what is available. And when we counsel based on what is available. And in terms of the child caregiver interaction, we avoid saying play more, stimulate development, be patient, and we focus on simple gains like hold the child closely, speak gently to your child, or speak as much as you can, maintain small routines with your child. And we simply frame it around that even when food is scarce, your voice and touch still protects your child. And to finalize that, the program in general, as I said, may contextualize the IYCF counseling into a specific context. In MHPSS without food response, risk appearing insensitive. That's why joint programming is essential. Over to you, Brooke.
Thanks, Najwa. That's super helpful. So we want to not only relieving some of this stress and providing this trauma-informed care. It's not necessarily that we're only talking about referrals to MHPSS practitioners or case managers. We can, in our role as the IYCF counselors or nutrition actors, we can know all of the referrals that can be given for food or vouchers or additional support. And this can continue to decrease some of the distress that people might feel. I want to look at this comment by Anthony. In an emergency situation, the mental health of both beneficiary and caregivers can be challenging. In such circumstances, it's also important to have materials for follow-up rather than relying solely on verbal communication, which is a fantastic point. A quick assessment guide or conversation guide available at the feeding center level. So there's some tools that can support kind of this engagement in these conversations, including a full assessment within the MAMI care pathway. There's a mental health aspect of the assessment guide there, and we'll be sharing some resources after this. But really, what we're touching on here is a much bigger conversation where it'd be really wonderful to see a lot more case studies and evidence and learning and sharing that from all of you. So as you do start to incorporate this, or if you have great learning opportunities to share with others, please do contact the IFE core group, the GNC, the field exchange, and let's continue this conversation past this webinar, because it's something that's very important and very critical to kind of the support that we provide. I want to say, sorry, I want to look at one other question. Sometimes when working with mothers and children, it's difficult to have a proper quiet space and to guide and help mothers with breastfeeding. Any recommendations for this? This is a very important part. It's a very important question, and you could see when the beginning of the role play video began, Mona did say, this isn't a very quiet space, but how can I help you feel more comfortable in the space that we have? So really talking and working with the family, working with the mother to say, how can I make this more comfortable for you? You want to try to get as quiet and as private as you possibly can. But the reality is that we're working in these very challenging contexts. Within trauma-informed care, we want to do the best that we can in the situation that's in front of us. And so really talking to them, what might make me feel private and comfortable might not be what makes someone else feel private and comfortable. So really doing the best you can, and then talking to see if there's anything additional that you can add. And then the very last, I haven't seen baby wearing supported in any of the materials. This can help provide privacy during feeding, warmth, and a safe place for the infant when the family is living in a displaced situation like a tent community. Absolutely. Understanding, and how Najwa just said as well, keeping the baby close, skin to skin. The baby also feels all that stress that's around. So really helping to support that calm and that engagement as much as we possibly can. Alice just shared in the chat recently conducted an MHPSS support group for mothers and nutritionally at-risk infants that was done in Somaliland. It's a great example of how some of this can be done and the realities of it in the field. It's a great resource to have a look at and to help think through kind of what you might be dealing with and how others have dealt with it. I can hand over back to you, Alex.
Brooke, if you can facilitate the poll, please.
Yes, thank you. Thanks very much. So we have another poll for us. We want to hear from you what the next steps you kind of can see. This is just kind of an opening to the conversation, right? An overview of what trauma-informed care means in our counseling and in our programming. So we want to ask you, what are some things that you identify as some quick action points, perhaps something that's a little bit longer that you can incorporate into your work? What are some of your perhaps needs that you identify kind of moving forward with all of this? So please, we'll give a couple minutes for the translators to also read this as well. Great. Maybe we can switch to the responses. Awesome. Okay, so we see a very high response for training staff on trauma-informed IYCFE. It's a great start, even just opening the conversation. So rather than feeling like you need to wait to have this big training developed and created, start where you are, right? Start with opening the conversation. This will be recorded, have staff watch, have the resources available to your colleagues. We're not talking necessarily, while it would be good to have a big training. We're not necessarily talking about some a very large comprehensive training. Begin the discussions kind of where you are, right? And identify with your colleagues how you can make those first steps. Another high one is including MHPSS considerations and nutrition and health assessments. Ideal. That's great. If you can add it to, if you're using you know, a version of an assessment that doesn't include it, look to that MAMI care pathway, MHPSS integration there. There's some full assessment forms for IYCF available that include considerations for mental health or distress, maybe is a better way to put it, to identify some of those points where you can support even more. And I see a lot for advocacy, also incredibly important. Strengthen referrals, important. Fantastic. And I look forward to hearing more about what you're all doing. There's the field exchange link is in the chat. Thank you, Astrid. So please reach out, share what you're doing. These webinars that we do are driven by all of you and your learning and your experiences and expertise. You're all the experts, so please share it wherever you can. And we appreciate it. Thanks. Alex, over to you now.
Yeah, okay. Thanks a lot, Brooke, and everyone else. So just a few next steps, and thanks to all of those that are still around the table, let's say the virtual table of this sharing experience. So once again, as you know, the Global Nutrition Cluster has been a key partner in this event with the infant feeding in emergencies. So just a reminder on how you can look for support. And these are some of the there is a link if you want to look for support through the ENET or directly to your Global Nutrition Cluster link and request for support. Sorry, it's not moving. And the request form is quite simple, as you can see, and you can just identify your location, type of question or support needed, etc. So through this form, the Global Nutrition Cluster will help you, will reach out and see in which ways they can extend support. Before closing, I really want to thank everyone, obviously the participants, all of you that are still with us, also those that for different reasons had to leave, the IFE core group, the GNC, and all the colleagues that you have heard and seen, and also those that you didn't hear that have been working behind the scene to be able to design and create this new format, if we can call it, of this webinar. Now, I know there are hundreds of participants still on the call. It will be really nice if you can, as soon as you close for this webinar, you will receive a link and provide an honest evaluation with your suggestion, with your thoughts. This is what we need to be able to design better events like this one. And again, challenge ourselves with new formats. So please take your 5 minutes, even less, to answer those few questions that will help us, as I said, improve what we do through these events and webinars. So again, all of these, the slide deck and some other resources will be shared. So thanks, everyone. Big congratulations to you all. And stay tuned for some future equally exciting opportunity to discuss and share your experiences. Bye. Take care.